first thing we'll talk about is taking a detailed diabetes history. We have to be specific and detailed to truly understand our patients and where they are on their journey with diabetes and how we can intervene. First, I ask my patients, when were you diagnosed with diabetes? This helps us understand how long they have been dealing with diabetes, but it also helps us understand where they are physiologically. Initially, in type 2 diabetes, we are dealing with mostly insulin resistance. These patients are secreting high levels of insulin, often higher than normal levels of insulin. But over time, the pancreas gets tired, it poops out, and we reach a phase of type 2 diabetes that is the pancreatic insufficiency phase. Patients who have had diabetes for 20 years or so will be in the pancreatic insufficiency phase. They may not do as well on oral agents or non-insulin agents, and we may be dealing with insulin for those patients. Next, I ask my patients, how were you diagnosed with diabetes? Were they losing weight? Were they having excessive urination or thirst? Were they hospitalized? We may be dealing with a patient who actually has type 1 diabetes, especially if they are a new diagnosis. We need to establish a diagnosis before we can move on. Next, I ask my patients what medications they are taking for diabetes. Oftentimes, patients tell the MA or nurse what medications they should be taking, what prescriptions are written for them, but they don't always give them details on how they are taking their medications and how much. This gives us details on non-compliance and also hypoglycemia for our insulin-treated patients. They may be skipping doses to prevent lows. Next, I ask my patients, what medications have you been on in the past and why were they discontinued? Oftentimes, patients were discontinued off of good medications for no great reasons. Other times, patients have had side effects to medications that you know that you won't want to use going forward. Next, I check my patient's A1C. Usually we find this in their labs, but we need to have a starting place for where we're beginning. Next, this is even more important than A1C, we have to ask the patient about specific blood sugars. The numbers are important. For example, an A1C of 6 may sound great on paper, but an A1C is an average. So that could indicate great control throughout the day, or a patient could have an A1C of 6% and having constant lows and highs from 40s to 400s, high glycemic variability. This is a highly dangerous situation that we have to address immediately. Next, I ask about hypoglycemia. You'd be surprised, sometimes patients don't outright tell you, so you have to ask specifically, are you experiencing hypoglycemia? If so, how low? And are you having symptoms? When patients become asymptomatic from hypoglycemia, they have something known as hypoglycemia unawareness. This is a highly dangerous situation because the patient's body has adapted to low blood sugar and has stopped producing the hyperadrenergic symptoms that tell people to go have some sugar to bring up their blood sugar. These are symptoms like clamminess, shakiness, tunnel vision, anxiety, agitation. These are protective mechanisms to prevent patients from having a very, very low blood sugar, like 20 to 30. Some patients have lost that ability because they have such frequent lows. Now, very low blood sugars, like 20s and 30s, can cause neuroglycopenic symptoms. This means the brain is not getting enough sugar to function. This is a potentially fatal situation. So we need to regain those hyperadrenergic symptoms in our patients before we move on in diabetes care. Next, I ask the patients about complications. Have you ever had a heart attack, stroke, stent? Have you had an eye exam? Do you have any diabetic retinopathy? When was your last eye exam? Patients need to be routinely screened for diabetic retinopathy because nobody has to go blind from diabetes anymore, but we have to screen so we can intervene early. Have they had any foot ulcers, amputations, numbness and tingling in their hands or feet? Any kidney problems from diabetes? This helps us stage and grade their diabetes. Next, I ask them if they're having acute symptoms. Are you having excessive thirst, excessive urination, vision changes. Next, I screen my patients for potential contraindications to some of the newer medications that we like to use for patients with diabetes. I ask my patients, have you ever had a history of pancreatitis? Or do you have any family history of thyroid cancer? These help us identify whether GLP-1 receptor agonists will be options for this patient. I also ask my patients if they've had frequent urinary tract infections or yeast infections. These tell me whether a patient is a candidate for SGLT2 inhibitors. Next, I move into my signature piece. I call it the day in the life. It's an hour-by-hour history of a patient's daily life. This gives you so many insights into their day-to-day life and enables you to identify areas where you can intervene on lifestyle. I ask my patients, when do you sleep and when do you wake? Do you feel rested when you wake up? Do you snore? These help me identify other potential comorbidities that could be making their diabetes worse, like obstructive sleep apnea or poor sleep in general. I ask my patients when they eat, what they eat, when they snack, what they snack on, if they exercise, how much, where, when, and with whom. I ask my patients to tell me anything in their day-to-day life that may be stressful, things that they have found as challenges. This day in the life piece is some of the most important information you can get before you create a plan for a patient with diabetes. To recap, we need a thorough history on our patients with diabetes. We need to understand the time course of our patient's diabetes to assess the accuracy of the diagnosis of type 2 diabetes, to understand where they are on their journey with diabetes, and how well their pancreas may be working. We need a detailed medication history. We need to know what they are taking and how they are actually taking their medications. We need to know what medications they have tried in the past and why they were discontinued. Sometimes meds that were discontinued in the past may still be options for our patient. We need to know details of daily blood sugar to assess patterns of hyperglycemia and hypoglycemia. We need to know about complications, and we need to know if they are up to date on screening for complications. The initial history is a good time to also screen for contraindications to GLP-1 receptor agonists and SGLT2 inhibitors. A day in the life history gives us so many important pearls about our patient's life and the obstacles they face toward getting healthier. This is also an opportunity to build a relationship with our patient and to ensure they feel heard and to let them know they are the central participant of their care plan. When we treat patients with empathy, patients do better. Every part of the interaction with our patient should be reinforcing that they are the driver of the ship on their journey toward better health. This helps engage them in their plan and empowers them to get to the next level with us as their cheerleader.